Ademola, great to see you here. So we can get started. Welcome and thank you all for joining us. Good morning, good afternoon, good evening. Welcome to this webinar on engaging drug shops for stronger health systems, which is being held at the same time as the launch of a special issue of the Journal of Pharmaceutical Policy and Practice. I'm Zubin from the Alliance for Health Policy and Systems Research. Could I have the next slide, please? So next slide, please. Just to let you know some welcome and housekeeping questions. If you have a question for any of the panelists, please use the question and answer button. And the session will be recorded and made available after the webinar finishes. So we hope that that is useful to you and will be made available on the Alliance website. So could I have the next slide, please? So just an overview of the next 1 hour. So I'll begin with a brief background of the research program, including how this was actually developed with implementer perspectives, as well as sort of implications that it has for health system strengthening efforts. We will then go on to 2 country presentations from Indonesia, which discusses a public-private partnership to increase access to artemisinin combination therapy, and from Nigeria, where we will examine how government initiative to increase access to injectable contraception through using the PPMVs, the patent medicine vendors, what are the factors that enable that. This will be followed by a panel discussion, which will enable audience participation and will encourage questions from you in this panel discussion. Could I have the next slide, please? So just a brief background. So we know the private medicine retailers or drug shops are a very important source of care, particularly in the rural areas of low and middle income countries. They are easily accessible. They often have opening hours which are much longer than formal providers. But we have concerns expressed about the quality of care they provide. Are they just providing medicines on demand? Do they have trained people in the drug shops to actually dispense medicines? And what is their linkage with formal health systems? They've been traditionally shunned by formal health systems and thought as outside the system, they contribute to low quality care. But realizing and recognizing the niche that they occupy, we increasingly see initiatives to engage them through training, through the provision of job aids, etc., to improve the recognition, through financial and other incentives, in return for providing information to the formal system and being in collaboration with it in return for this recognition. So we see a wide range of initiatives which we'll examine here in this research program and the webinar. I get feedback that sound is bad. Am I easily audible, Jeff?
Just stay close to the computer.
All right. So we need to learn more about these initiatives and systematically study their implementation on how these can contribute to the objectives of the health system. Could I have the next slide, please? So this research program is a collaboration between the Alliance for Health Policy and Systems Research and the Implementing Best Practices Network, both based at WHO. And this program is supported by USAID. We took implementer perspectives into account to design the research goal. We had a stakeholder workshop with over 25 CSOs and NGOs to identify gaps and challenges where evidence was needed. We heard from implementers the need to understand how these initiatives could be used to strengthen supply chains, to understand better what sort of training would work or not work, what sort of financial incentives or other incentives drug shops were going to respond to. And based on that, we developed a call for research, for implementation research, which was issued in early 2019. We had almost 40 applicants, and we had 7 research studies were selected. Could I have the next slide, please? We see here a wide range of both countries as well as topical areas. So we see 3 countries from Asia and 3 countries from Africa. In terms of topical areas, we see initiatives that focus on malaria, those that focus on tuberculosis, those focused on family planning initiatives, as well as more broad issues such as antibiotic resistance, guidelines designed by national governments on operating drug shops and their acceptability, as well as efforts to actually bridge the drug shops and the formal health system. We see a wide range here, both in terms of sites, as well as topical issues covered. Could I have the next slide, please? So as we go through the country presentations, it'd be good to think through what are the kinds of implications these studies raise for health systems. So as I pointed out just now, what are the kinds of incentives that matter? Are these incentives just financial or others, such as recognition? How do we balance regulation with maintaining drug shop interest in engaging with the formal health system? So what are the sort of disincentives that we should avoid in terms of regulation that overburdens? How do we manage relationships between the formal health system and drug shops? And this is, of course, historically many years of antagonism in several settings. How do we overcome that, move towards a more constructive relationship? How can governments effectively skill up drug shops? And what are the elements of training that matter most? Training is a very broad word. What should we look for in training? And then finally, how do you make sure that these initiatives can serve as entry points for using drug shops across both a wider range of services, so moving from initiatives that focus on only one disease to a broader set of conditions, as well as how can these actually serve, so the sort of demonstrations that we have of them coming into the regulatory system, feeding into government information systems, supply chains, what lessons can we learn from these about larger integration of the private sector into the formal health system, particularly the informal private sector. Could I have the next slide, please? So just a brief overview of this journal supplement, which has just been launched earlier today, and the link for which is there below. We have 6 research articles, a paper on the cross-cutting lessons learned, and 2 editorials. And we encourage you to visit the site and learn more about these individual articles and the broader lessons from this research program. Could I have the next slide, please? So now I'd like to introduce our 2 presenters. Ari Prabandri, Professor Ari Prabandri is a senior researcher at the Universitas Gajah Mada, and she has a focus on disease control, health policy and systems research around disease control, focusing on mixed methods and qualitative research. We also have with us Dr. Ademola Ajuwon, who is based at the College of Medicine at the University of Ibadan in Nigeria, whose work focuses on reproductive health issues amongst adolescents, HIV prevention, and social media, and the role of social media. So I'd like to now hand over to Dr. Ari Prabandri to discuss the initiative in Indonesia around the provision of artemisinin combination therapy to deal with endemic malaria. Over to you, Ari. You have 10 minutes for your presentation.
Thank you very much, Zubin. Thank you for the opportunity to present the findings from our study about the role of private pharmacies in provision of artemisinin-based combination therapy for malaria control in Manokwari District, West Papua, Indonesia. So artemisinin-based combination therapies, ACTs, next slide please, have been recommended by WHO as a standard treatment for uncomplicated malaria, and Indonesia also endorsed that provision for controlling malaria in endemic area. And Papua Barat province is one of highly endemic area for malaria in Indonesia. So that in scaling up the coverage of ACTs for the community, the Papua Barat Province Authority provide initiative of a public-private partnership for ACTs provision. Next slide, please. The PPP initiated in 2012 with starting of distribution of ACTs to private pharmacies, and it's systematically implemented in 2017 by some meetings with stakeholders, particularly private pharmacies, and memorandum of understanding with private pharmacies and district health offices. So in the initiative, the district health office provide free ACTs in private pharmacies. They also provide training for private physicians to prescribe ACTs, as well as the training for microscopists for private laboratories. And the district provide quality assurance with cross-check of microscopic sample from the lab, and provide as well the logistic for diagnostic tests. Slide, please. And in this initiative, the patients who would like to get free ACTs from the private pharmacies should go to the physician for examination, as well as for laboratory tests with blood smear tests. And then after the diagnosis based on the laboratory tests, the physician prescribe ACTs, and the patient can go to the selected pharmacies that provide ACTs for free. And the private pharmacies can get the free ACTs from district health office with some kind of procedure of reporting and procurement. Next slide, please. So our study focused in 3 research questions. The first about the extent of the involvement of private pharmacies in ACTs provision in malaria treatment. And the second one, to explore the barriers and facilitators to initiate, implement, and sustain public-private partnership of ACTs provision. And we would like also explore the experience of patients in assessing ACTs in private pharmacies. So we particularly explore 3 implementation outcomes, which are coverage, acceptability, and sustainability in relation to ACTs provision through private pharmacies. Next slide, please. We collected both qualitative and quantitative data. We use secondary data from malaria control program in Manokwari district, as well as conduct FGD in-depth interviews with stakeholders, including program implementers, client, and provider. Next slide, please. So about the findings for the coverage implementation outcome, we found that actually one potential of including private pharmacies, which is that's already familiar by the community. It's easy to reach by them, and there are also flexible operational time for the private pharmacies, and it's perceived as a benefit for the community that ACTs can be obtained free by the patients. However, if we see the data about the growth of private pharmacies involved in the PPP initiative, it's a bit slow, because in the last 3 years, the total of private pharmacies that participate in the initiative is only about 13 to 14%. So compared to the growth of the overall private pharmacies in the area, it's low. And then not all physicians actually prescribe ACTs, because we found as well about 15% of the patients still receive monotherapy when we assess the prescription of the physician in the private pharmacies. Next slide, please. While PPP initiative is perceived as a good things for the community because it's provide ACTs free of charge for the patients, however, there are some barriers related to the acceptability, because private pharmacies perceive burden of reporting and procurement process related to ACTs, and there is also some barriers because of the lack of income. Actually, the PPP initiative was designed that the private pharmacies could obtain income for the sales of other drugs prescribed together with ACTs, but the private pharmacies perceived that it was not a benefit for them. So also, next slide, please. The other barriers was related also with the sustainability, because the current funding of the PPP was mainly from external funding. And also there is lacking about mechanism for monitoring and evaluation. We found unavailable written SOP or technical guideline in relation to the implementation, and also lacking of information disseminated to newly established pharmacists or private practitioners. There are also limited human resources in the private pharmacies to manage this initiative and perceive no sufficient reward for them by this PPP initiative. Slide, please. So that based on that findings, we propose some policy implication that improve coverage, acceptability, and sustainability for this PPP initiative, particularly about the recruitment of the new pharmacists in the initiative by disseminating the information, relevant information, to the new private pharmacists established in the area, as well as with professional association, because without any proper dissemination to the physician as well, the PPP initiative was facing some barriers related to the implementation. And then we also propose some kind of capacity building for physicians as well as the private laboratory analysts to support the PPP initiative, and the development and dissemination of technical guideline and SOP. And in order to improve the acceptability, we propose some kind of simplification of the process of ACT distribution to private pharmacies. Decentralized authority for distributing ACTs seems essential here. For instance, that the district health authority can delegate the ACT distribution to community health center nearby in the private pharmacies, so it will reduce the cost related to the restocking of the ICTs. And then integration of the data from private pharmacies into routine surveillance will be essential as well, because we can facilitate the monitoring and evaluation by integration of the data with the routine surveillance. And to improve the sustainability, the role of the district authority and provincial authority as well will be very important, because internal funding should be provided to ensure the sustainability of this initiative. And we also recommend the monetary and non-monetary incentive for the private pharmacies. We propose that we should finding the right balance between social and economic perspective in this initiative. And of course, here, the inclusion of the owner to have a similar awareness about this initiative will be also important. So that's all. Thank you very much. We thank Ministry of Health, Republic of Indonesia, Provincial Health Office of West Papua Province, Manokwari District Health Office, as well as the Polytechnic Kesehatan, Kemenkes Sorong, for support to this project. We thank also for all study participants, and last but not least, we thank the WHO Alliance for Health Policy and System Research for funding this project. Thank you very much.
Thank you, Ari. So just a couple of reflections. I think we see here an initiative where clearly having access to artemisinin combinant therapy seems to have been improved by the free drugs being given. But here we see that not thinking through all the parts of the health system together have led to probably a suboptimal outcome. We, for instance, not thinking through the kinds of incentives the drug shops have, not even looking for opportunities to actually integrate this into the system as a whole, for instance, about supply chains. And also that when you're thinking through the incentives for drug shops, it's not just financial incentives, it's also the disincentives of burdensome reporting requirements, burdensome procurement processes. So all of these, I think, are important areas when designing public-private partnerships going ahead. So with that, thank you very much. I'd like to now hand over to Professor Ademola Ajuwon to discuss the initiative from Nigeria around injectable contraceptives.
Thank you. Good afternoon, everyone. Greetings from Nigeria. The title of my presentation is Using Patent Medicine Vendors to Enhance Access to Injectable Contraceptive in Nigeria, a Process Evaluation. Next slide, please. So the background information is that in Nigeria, modern contraceptives are still underutilized, and only 12% of currently married women and 28% of sexually active unmarried women use the modern contraceptive. This is from the latest National Demographic Health Survey. However, among the modern contraceptive being used, the injectable contraceptive is the most popular, accounting for 30%. Research has shown, and our programmatic experience has also demonstrated, that there is a potential for patent medicine vendors, PMVs, to improve contraceptive, since they play an active role in the delivery of basic healthcare services in the country. PMVs operate in the informal sector of the Nigerian system, and they are the primary source of non-prescriptive contraceptive services in the country. Next slide, please. So, the Population Council, in collaboration with the Federal and State Ministry of Health, between 2015 and 2018, implemented a two-phase project that trained 381 PMVs to deliver injectable contraceptive in drugstores in 6 of the 36 states of Nigeria. The goal was to determine whether it is feasible for PMVs to actually administer all types of injectable contraceptive, particularly Depo-Provera and Cyana-Pres. Now, the evaluation of that project showed that it was feasible to train PMVs to deliver injectables. There was also improvement in the uptake of injectable by clients who accepted the services provided by the PMV. However, as at the time we conducted our survey, our study, not enough information was available on how the intervention actually worked. So we picked this up as our research objective, and with the funding from WHO, we were able to implement the project. Next slide, please. So we conducted a study in 2019 in 3 out of the 6 states where the initial project was conducted. We did face-to-face interview, and we also interviewed 145 female clients. We also had a qualitative component where we interviewed 27 stakeholders, as shown on the screen. Next slide, please. So these are our findings. So we assessed the knowledge that the PMVs had from the initial training that they received in the project that I referred to between 2015 and 2018. And as you can see in this slide, many of them had complete knowledge on injectable contraceptive. You can see 96.4% had complete knowledge on Depo-Provera, almost the similar high level of knowledge with Norestia and then Cyana-Pres. So many of them retained the knowledge on injectable contraceptive that they received from the initial training. Next slide. So we also asked whether they had injectable contraceptive in their shops. And as at the time of the interview, majority, 72.9, approximately 73%, still had Depo-Provera. 61 had Norestra, and 45% still had Cyana-Pres. It must be emphasized that the project had already been completed, and for the sake of the project that was done initially, they were allowed to provide injectable contraceptive, because as at the time this study was done, this category of health workers were not allowed to provide injectable contraceptive. Next slide, please. So what were the contextual factors that facilitated the provision of injectable contraceptive? The PMVs themselves told us that the training that they received was competency-based, as you can see in this quotation. and I read, the most significant is the training itself, because we now know exactly what to do. So this is a statement, part of a statement from the PMV from one of the states. The second contextual factor was the approval that was given by the regulatory agency for the provision of injectable contraceptive by PMV throughout the duration of the study. They were also provided with job aid, which was meant to provide them instructional materials on how to deliver appropriate services. However, as at the time we did our study, only about 28% of them reported that they actually use this aid for their clients. Next slide. So what are the broader effects of the intervention on the health system? We identified 4 of such effects. Number 1, the PMVs, they bridge injectable contraceptive service gaps in Nigerian health system. So these people, clients go to them because these services were not available in the former healthcare system. And clients had trust and confidence in this category of health workers. And so that was what made them to continue to patronize them. We also found that more partners and donors were willing and interested to implement similar interventions through the PMVs based on the success that was recorded on this particular project. The third effect was that the intervention facilitated more interaction and collaboration between PMVs and relevant government agencies working on health issues. Prior to this project, there was always tension between PMVs and regulatory agencies, including Pharmacy Council of Nigeria and other sectors in the health ministry who perceive the PMVs to be quacks, to be untrained. But this project facilitated closer interaction between these two categories and showed the potential that these two can actually work collaboratively to improve the healthcare delivery system, particularly in relation to family planning. The last effect is that the potential for task shifting was demonstrated. It was shown that PMVs can actually deliver injectable contraceptive, and therefore they can improve the contraceptive prevalence in the country. Next slide. So the enabling regulatory and support environment, moving forward now, we talk about the implication of this project. The regulatory authority must define the scope and practice of PMVs, and their function should be specified in order to integrate them into the formal healthcare system. Right now, the PMVs operate in the informal sector, but this research has shown from our evaluation that the potential is there for them to make important contribution into the delivery of family planning services. However, they need to be integrated into the formal healthcare system. Nigeria is currently developing a plan to have a tiered system of accreditation where trained PMVs will be accredited. And with this accreditation, clients who need their service can access injectable contraceptives in their shop. The other policy implication is that the reform should address several systemic issues, such as licensing, training of human resources in the patent medicine stores, contraceptive logistic management system, data management, monitoring, and supervision. It's not simply enough to say government is going to integrate this group of health workers into the health system. There must be policy in terms of licensing, in terms of training, so that this category of healthcare workers can make important contribution to the delivery of contraceptive services. We found from this project that training was a critical intervention that enhanced the capacity of PMVs to provide injectable contraceptive. So government should develop standardized curriculum that should be manual, and training should be done in such a way that PMVs are made to be safe contact to their clients. Next slide, I think that should be the end of it. Next slide, please. Now, conclusion. We know that PMVs continue to play important roles in family planning services. The PMV deliver injectable services in response to the needs expressed by women. This reflects the weakness of the current healthcare system, which is unable to respond to women's need for timely access to contraception. And this underscores the need to formalize and scale up this intervention to aid their integral roles, coupled with multifaceted initiatives to enhance the quality of their services. Achieving global initiatives such as the Family Planning 2020 and the Sustainable Development Goals target of achieving universal health service to family planning will require the formal integration of this category of healthcare workers into the private sector. So on that note, I make a conclusion and thank you for listening. I want to acknowledge the support that we have received from WHO right from the beginning up to the end of the project. I also want to acknowledge our participants, without whose cooperation it would have been impossible to do this research. And I want to thank you all for your attention. Thank you and God bless you.
Thank you very much, Ademola. I just wonder, does it sound better now? Let me get some feedback.
It's better, Zubin, thank you.
Okay, thank you. Yeah, I've made up a few changes here. So thank you. We see that competency-based training was crucial to the success of this initiative, and also that government space in terms of giving regulatory approval for the duration of the pilot was important in increasing acceptability. So I think we have to reflect on how regulation needs to be appropriately designed and be realistic to actually match the situation on the ground. So now, thank you very much for the presentation. Lydia, could I have the next slide, please? I'd like to introduce our panelists in addition to the presenters. So we have here with us Baker Magwa, who is a senior fellow at the Population and Reproductive Health Department in USAID, where he provides strategic planning for PRH research as well as for implementation of different initiatives. Zahir Babar is a renowned scholar in the area of pharmaceutical policy and practice, a professor at the University of Huddersfield and the director of the Center for Pharmaceutical Policy and Practice there, and also the editor-in-chief of the Journal of Pharmaceutical Policy and Practice. We have Elizabeth Shekalage, who is the CEO and registrar of the Pharmacy Council of Tanzania, with a critical role in the development of the ADO initiative, which is of course well known in terms of engaging drug shops. And we have it as Ado's me from a senior technical advisor at the Implementing Best Practices Network Secretariat. And he works in the area of documenting best practices in family planning, knowledge management, and other related activities. So thank you very much for joining us here. What I'll do is have one round of questions for the four panelists, and then we open it for asking audience questions. Please, audience, place your questions in the chat, in the Q&A box, rather than the chat box. It just helps and makes it easier. I will look at the chat box also for a few questions, which have already been placed in the chat box. So my first question is to Elizabeth, and the public sector and CHWs in many countries have kept an arm's length from private drug shops. As someone who worked in one of these research studies, but is also a policymaker, how do you think this relationship, this somewhat adversarial relationship between the formal system and the drug shops can be changed, and some specific strategies you think that might work for this? So if you reflect on this in about a minute or two, over.
Thank you so much, Zubin. Good afternoon, everybody. I thank you for the opportunity, and I would like to share regarding the study that we did, trying to see how the public system is connected to the drug shop. To begin with, I would say that implementation of drug shops initiative in Tanzania was trying to address the public-private partnership. However, we found that there was a gap between the public health system and the private health system in terms of working relationship, in terms of collaboration and communication. And therefore, our study focused to see what are the gaps that are existing. And we try to initiate how to build the gap through training that we did in one of our area here, local area. Maybe to, because of time, but I would love to say that in Tanzania, more than 80% of our population, when they get ill, they visit drug shops. And therefore, sometimes we thought these drug shop sellers, because of lacking of communication, they were trying to struggle how to help these people without doing a referral to the nearby health facility. Of course, we have health facility, we have drug shops, but again, we have community health workers. And community health worker is a voluntary job. They are not getting any incentives, so they were left behind. So our study tried to see all these 3 points and how can we connect them and become one. Of course, we realized that the key issue is training, how to, first of all, how to trust one another, because if somebody was treated in the drug shop and later on going to the public health facility, sometimes he was not received well. Like, you know, you try, they were commenting that you have been to the drug shops, it seems you are very rich, so why are you coming to us? So we try to build a gap by trying to find a relationship. And our study was also looking before the training and after the training. So we realized the importance of training in relation of linkage among the drug sellers, community health workers, and health facilities. And we have seen a very significant added value in it. Of course, we explored further. There is a study which is now going on that we went further to digitalize the system so that it can be easily monitored. And of course, we are very much interested with referrals because in Tanzania, unfortunately, in drug shops, you cannot conduct any diagnosis. And therefore, in addressing also the issue of irrational drug use, we normally identify danger sign and other danger symptoms. And of course, we need to refer a patient or a client to a nearby health facility in order for them to be diagnosed. After they have been diagnosed, if at all there is a shortage of drugs or out of stock, then they are referred back to the drug shop. So that relationship has been built so far here in Tanzania.
Thank you.
Maybe to start with, I can just comment on that. Thank you.
Thank you so much for that intervention. I'd like next to ask this question of of Magwa. And USAID has long supported programs to engage drug shops, particularly in the area of family planning. And what does USAID see as the added value of implementation research in general and this research program to your work and your implementation work? Over to you.
Thank you very much, Zubin, for the question. First of all, I'd like to congratulate you and the team at WHO, and also the researchers, who designed and, conducted and implemented the studies and have produced these great manuscripts. Now, from USAID's perspective, USAID did realize, the need to expand service delivery options to include drug shops more than 2 decades ago. The challenge at the time, and which continues up to today, is that there is the evidence to kind of support the value add in terms of engaging drug shops as part of the service delivery platforms. So since then, USAID has been investing in generating evidence to support the concept that yes, drug shops have a critical role that they can play and that they can actually add value, not only in terms of increasing coverage, but also in ensuring equity and scalable approaches to provision of family planning and also other services. Now, apart from supporting research, USAID at the mission level, many of the programs at the missions have also kind of come on board, and they are already including, drug shops in their bilateral procurements. But again, the question usually is, where's the evidence? Where is this? And one of the ways that the evidence that we have so far has been used has been in the development of the high impact practice brief on drug shops, which I believe, others, may talk a little bit more about that. It was recently revised using evidence, but still we kind of like still when you go to the tag, people still kind of say, hey, give us more evidence. So I'm just giving a little bit of that, that background, then to kind of like wrap it up and say, we were really excited when WHO came up, with the idea that, we could kind of do some more implementation research around this subject, not only looking at family planning, but also other, other programs as well. And we do believe that, this evidence that has been generated does deepen and broaden our understanding of, the implementation science behind, drug shops. And we will definitely continue to use this evidence to inform, our programs centrally, and also our programs, through the bilateral programs, and to kind of use this to help us, formulate and engage in a more evidence-based manner. I think that's that, and we hope that, we'll continue to do this, and we're looking further to collaborating in terms of how we can be able to disseminate, this important knowledge to ensure that, it gets to the people who want to use it and who will use it. Thank you.
Thank you, Magwa. I think that's an important point you raised, that we've got this new body of knowledge. We now need to work more closely to actually disseminate it in forms that are often useful for implementers. Having articles is only one step in this, and I think that's an excellent when you're taking this forward. So actually, I'd like to now bring in questions from the audience. I see in the Q&A before coming to the other two panelists. So there's one question on sustainability and scale up, and any discussion of integrating pharmacies. Sisek asked this question. Is there any awareness amongst the panelists? So I pose this to Ari, to integrate pharmacy or drug shop-based care into national state level health insurance schemes to reimburse them for that care. So Ari, it would be great if you could actually present this to the whole webinar, and if you could just give us your reflections on this.
Thank you for
tying up with the health insurance schemes.
Yeah, thank you for a very interesting question. Yes, in Indonesia, there has been initiative to encourage pharmacies to have cooperation with national health insurance scheme. Right now, the level of coverage of national health insurance scheme, we are still try to increase that coverage. So that's actually the PPP initiative on ACTs actually want to cover all the malaria patients who need ACTs, whoever they are, covered by health insurance or not. So I think when the coverage of the national health insurance is improved, I think it's also opportunity to integrate the ACTs initiative, PPP initiative with the national health insurance system. Thank you.
Thank you for that. Now moving on to a question for Zahir. As somebody who works in the area of pharmaceutical policy and practice research, I'd like to, and including high-income countries, what do you see are the primary main learnings from this body of work in the journal that we do?
Thank you so much, Zubin, for asking me this question. To me, I mean, looking at these studies, and again, I would like to congratulate you and team for actually, and the researchers for coming up with this. I think there are 2 or 3 sort of major things which have come up from these studies. One is, of course, the financial incentives, and financial incentive is something which we see across the board, not only in lower strata of the low income countries, but we also see in the middle income countries and high income countries, because wherever we want to introduce pharmacy services, and in a way, some of these things, whether it's tuberculosis counseling or reproductive counseling, some of this could come under sort of, pharmacist-based services. So where the financial incentive is something which is pretty important. And I think there is a synergy. You could see that actually this is the same thing in high income countries and low income countries at the different level. The second point, which has actually struck me quite a lot, is about the image of drug seller. And this is what we have seen in the studies, for example, in Nigeria, where actually there were sort of, there were misconceptions, and also seen in, for example, Myanmar, they were distrust. And this is, we are talking about an informal drug seller setting. But this is, again, what we see in very high income countries as well, that there are issues with the pharmacist perception. So for example, when the pharmacists are providing counseling and education to the patients, then they're always questioned in terms of their level of expertise and knowledge. So I think this is coming across the board, the financial incentives as far as the training and education. So the need is not only important, for example, of course it's important in the formal pharmacy sector, but informal sector, where we see these number of studies coming from, whether it's Indonesia, Myanmar, Nigeria, or other countries, there is a need to have that, to have the financials built up. And I think the third important thing, which is about health system, and I'm sure that you would agree with me that low and middle income countries are not homogeneous countries. They are very different countries in terms of their structure and setup. Some of this could be very organized at the pharmacy level, whereas some are not that organized at pharmacy level, and some is a mixture of these two. So it's important to understand that categorization in the health system.
Sorry, Zahir,
it's quite an eye-opening, basically, and there are lessons. Sorry.
Sorry, Zahir, could you just repeat the last point, please? The last point, because
the last point I was talking about, the low and middle income countries are not homogeneous countries. They are very different in terms of their health system and health setup. In some countries, we see that basically there is a very big formal sector in terms of retail outlets. In some countries, there is a small setup for for informal sector, and some there is a mixture of this. So I think if we are developing sort of interventions, then need to take into account according to each country health setup or health system. But nevertheless, I think financial incentives, education for the drug seller, procurement practices, these are sort of things which are quite common and commonality, I would say. And this is also common when we talk about the pharmacist role in high income countries, financial incentives and education and upskilling and training.
Thank you, Zahir, for those reflections and for discussing the differences amongst LMICs and also commonalities with HICs. Yeah, we need to get over this dichotomy of HIC as one and LMIC as one, and then the complexity with LMIC.
Yeah.
So thank you for that. I'd like to now pose a question to Ados. And in terms of understanding, as someone who works in knowledge management space and taking findings of research into policy, what you see as the kind of knowledge from this body of work that actually inform your work in implementation, particularly in advocacy work that IBP Network does in best practices around that.
Thanks, Zubin. Thanks for the question, and congratulations to all the authors for their amazing studies. The IBP Network convenes partners to share effective practices and tools that support family planning and reproductive health programming. We work to, one, disseminate evidence-based guidelines and high-impact practices. We also support the implementation and use of these guidelines at the country, national, regional level. And we facilitate better collaboration and partnership between stakeholders in the FP arena. In the context of IBP's work, the added value of implementation research, and in the case of this supplement, is an opportunity to better understand the processes to engage drug shops in the delivery of specific services. The number of partner organizations that have implemented drug, shop, and pharmacy programs, and also documented effective practices in our network is increasing. And we're very happy to see that. And it's important for me to also stress that our network is a network of implementing organizations. We know that engaging implementers in developing the research agenda results in knowledge that is relevant to real-world program implementation and application. Recently, our members have published important tools on drug shops. First, MexFam, the IPPF member in Mexico, in collaboration with us, published an implementation story on training workshop operators to better serve adolescents. And we think this is a very innovative approach to their work. In addition, FHI 360 published this year a handbook on drug shop operators' provision of injectable contraception. And as Marwa mentioned, the High Impact Practice Partnership recently updated the drug shops and pharmacists HIP brief. The sharing of knowledge and experience among our partners provide us additional evidence to make adjustments in implementation, and also make smaller adjustments to their programs. So we have an opportunity both to look at adjustments or changes at scale, but also making a smaller tweaks to already successful programs and programs that are having an impact on the ground. The studies of this supplement really enrich the knowledge base of the family planning community and offer us an opportunity to learn from specific country experiences that can be taken to scale and replicated in other countries. Thank you.
Thank you, Ados. So I have a couple of audience questions coming for Ademola in particular. So a question from Nita Bhatnagar: was the training followed by supervision or mentorship to assess for competency? And if yes, who supervised it for how long? This is, of course, a very important question on how you ensure the training has actually had its effect or not. And following up on this also, from a question from Chris on how are PMV accessing injectable contraceptives? Was it commercial or was it social marketing for Sayana Press in Nigeria? Ademola, if you could have some responses to this.
So the question on mentoring and supervision, actually training was a key component of the research. So the PMVs were trained for 1 whole week, and the training was very rigorous. It's only those who, after the training, were assessed and found to be competent that were allowed to actually participate in the project. And for the entire duration of the research, there was monitoring and there was supervision. So on a quarterly basis, a team from the ministry, from the Pharmacy Council, paid visit individually to some of the PMVs. And this served as a morale booster to the PMVs, and it was very, very encouraging. So we found from our evaluation that played a very important role because it boosted the confidence of the PMVs to actually provide the service. And the fact that the PMV was being visited by somebody from the ministry, from our capital, Abuja, gave a lot of morale booster for the PMVs. All this we found to be the case. Now for the second question, in terms of where they access their supplies, if I get the question correctly, the program was planned in such a way that one pharmaceutical company was going to ensure that supplies were available, particularly for Sayana Press, which was new in the country at that time. Unfortunately, this did not work so well. So the PMVs, they had to rely on purchase of the Sayana Press, another drug from the open system. And we know that that is not good enough. And that it is one of the things we recommend, that if you want to take full advantage of the contribution of the PMVs, you need to do the following. First, acknowledge that they are contributing to family planning service in the country. Second, formally integrate them into the system. Thirdly, you need to train them. And after training, you give some form of accreditation in such a way that people know that this group of health workers have been trained. After accreditation, you need to create a supply chain so that PMVs can have regular supply of contraceptive, particularly injectable, from safe sources, so that they will be able to provide safe services for their clients. And later on, you need to continue to monitor and supervise this category of health workers. So these are the steps that the country needs to take in order to take full advantage of the potential of this category of health workers. Thank you, and over.
Thank you, Ademola, for that very comprehensive response. We're coming up to the hour, and I'd like to then invite Dr. Abdul Ghaffar, Director of the Alliance of Policy and System Research, to provide closing remarks for the webinar. We've completely run out of time to take a rich discussion, two excellent presentations, and there are many more questions to be posed. But since we are at the end of the allotted time, I'd like to invite Dr. Ghaffar.
Thank you, Zubin. And I have an easy job. I have to just say thank you to everybody. So first and foremost, I'm very pleased to convey my appreciation and thanks to Professor Zahid Babar and his team, because without their support, guidance, and effort, we should have not had this peer-reviewed publication, which is an important in the eyes of the researchers, and that's the way we have been able to showcase our work. Second, to our partners and funders for this research, especially our colleagues in the USAID, Sean and Magwa. Without their financial support, guidance, and continuous support, it would have not been possible. But also our colleagues in the implementation best practices team within the WHO. So we are very grateful to their collaboration and support. Third, and most important, to all the panelists, I think it was very interesting studies which you have presented and the way you have presented. To all the country teams and the participants, most important, all of you have been able to join this effort, and this effort is not over. And the reason it's not over, there's some sort of continuous, like sort of a contest between two groups in the health system. The people who just believe that we should not compromise on the quality of care, including supply of drugs and medicine. And the other group is, which is more pragmatic and more close to the society, is increasing the access and availability of drugs and supplies to the people, especially into the low and middle income countries and the resource poor settings. Obviously, we have found a lot of evidence that availability and access of the drugs through the drug shops makes a lot of sense and definitely increases the access and therefore improves the performance of the overall health system, which is beyond 6 building blocks, but in the end, it's the people which matter a lot. So I think this debate and discussion will still continue. So we are not asking you to take a particular position, but we are very happy that you have participated in this discussion and dialogue. But it remains a challenge. There is an issue, whatever your position is. One thing we need to ensure that people and citizens of all countries and places have access to good quality services, including drugs and supplies. In the end, I have to say thank you to my team, Jeff, Livia, Tanji, and most important, Zubin, for your hard work, leadership, collaboration, coordination, and getting this work done. Collaboration is never easy. You have to work with different people, and there have been challenges because of the ongoing pandemic, but we are very happy we have been able to do this thing. So thank you, Zubin, for your leadership. And with these remarks, again, thank you to everybody for participating in this webinar, but also participating in this study, which is, I believe, very important when we have to look how can we have the better functioning, stronger health systems. Thank you. And Zubin, back to you.
Thank you, Dr. Ghaffar, for those remarks and encouragement. And with that, we come to an end of the webinar. Thank you very much for participation. Thank you to all the panelists for the time you've taken out from your schedule to be here, and to all the research teams for their effort in providing the studies to us, working with us the last 1.5 years. And thank you to the collaborators, USAID, the IBP, as well as GOPP for their support. Thank you very much and goodbye.